welcome everyone. My name is Meredith Lee. I am the lead for the Women in Data Science Datathon, part of a very diverse committee of folks from academia, industry, nonprofits, and government who have been working throughout the year to provide this data set that has been so exciting this year about health data from intensive care units. I'm so delighted to have so many panelists here in person and also in spirit to share some lessons learned and best practices around health data. I'll let folks introduce themselves in a little bit more detail in terms of how they got started working with health data and their roles right now. But just to give you the titles and where they're from, we have Vani Mandava. Vani is the Director of Data Science at Microsoft Research. She's been on the WiDS Datathon committee nearly since the beginning, and you may recall her from last year's quite popular WiDS Datathon webinar focused on deforestation. We also have Carly Eckert. Nice to meet you, Carly, for the first time. Thanks so much for joining. Dr. Carly is the Director of Clinical Informatics at KenSci, and also has a really interesting history with the state of Washington, and I'm sure she'll explain additional context. Thanks for joining us. I know it's a very busy week for those in public health, particularly Washington state as well. We also have Leo Anthony Celi, MD, MS, MPH, and more. Leo is part of the MIT consortium around data science, as well as the Beth Israel Deaconess Medical Center. His team is responsible for getting this data to you with the help of folks like LaTanya Sweeney from the Harvard Data Privacy Lab. And in spirit, we have Marzyeh Ghassemi. Dr. Ghassemi is an assistant professor at University of Toronto. She says hello. She's lecturing right now, doing double duty at the University of Toronto. She was one of the very first people more than a year ago to suggest that we look at health data, which clearly was popular from the number of participants this year in the Datathon. And besides leading the Datathon, I am also the executive director and a co-principal investigator for an organization called the West Big Data Innovation Hub. We're so excited to partner with WiDS again this year for the third time with this Datathon. Hopefully the slide just changed and you get a sense. This was shown at the conference on Monday of the over 200 different events globally. In addition to the 60 or so countries that are hosting in-person events that are tuning in to the live stream or replaying the live stream from Monday, the number of countries of registrants for the Datathon was really impressive. We had folks from 85 countries, and that's after some deduplication of the data participating in the Datathon. So we're giving the conference organizers a run for the money in terms of numbers of countries participating, and it's so great to see that throughout the community. For those who didn't tune in to the announcement on Monday, we unveiled the top 3 winners. And this is out of 951 teams, which is 4 times the number of teams that we had last year. You may have seen the New Yorker artiste. And this is really, I'm just showing this to note that all of the small group discussions and efforts that folks are doing around the world are really the heart of this effort. So without further ado, we will say thank you to the collaborators, many of whom are represented here. Also, we'll tell you a little bit more about the WiDS Datathon Phase 2 and the Excellence in Research Award. But to really frame that, we wanted to give all of our panelists a chance to explain how they've been involved in health data research so you can get inspired for your Phase 2. So let me turn this over to, I think Carly was first up to give a little bit of background and some insights about her work with health data. Carly?
Great. Good morning, good afternoon, everyone. Thanks for attending. So my name is Carly Eckert. I'm a physician by training. I started out kind of in the clinical health space, initially in general surgery, and then have sort of moved into public health and epidemiology. Over the last few years, I've kind of had a variety of different positions and organizations that I've had the opportunity to work with, including, as Meredith mentioned, the state of Washington, doing some research with catastrophic injuries, and that's kind of how I got into working with health data. Over the last few years, I've transitioned a little bit more into the space of clinical informatics and kind of gotten deep into that space working with KenSci as the director of clinical informatics. So I work closely with our data scientists and engineers, actually, as we apply, some of our predictive analytics to healthcare and healthcare problems.
Fantastic. Vani, could you give a little bit more detail in terms of what excites you about health data and your background?
Absolutely. Hi, everyone. My name is Vani Mandava. Like Meredith said, I work at Microsoft Research, which is a research organization that spans several countries in the world. We have over 1,000 researchers, and our mission is to push the state of the art in computing, in technology, and in AI in collaboration with industry, academia, and government. My team is especially involved in that collaboration piece. We help find collaborative opportunities between academia and Microsoft Research. And a big part of that I am passionate about is the data assets that we produce as part of the research outcomes that we publish need to be discoverable and need to be usable so that the research can be reproduced and others can build upon the research that we do. To that end, we have a service called the Microsoft Research Open Data, where we have published data sets that have been curated by Microsoft researchers. We have about 82 data sets there. There's very few health data sets there, but we continue to onboard new data sets, and we follow a fairly rigorous process in how we get data into Microsoft and also how we release data out for public consumption. So that's broadly the area that I work on, in addition to human AI collaboration and some other fields of data science. It's really great to meet everyone, and I especially want to thank all the participants for their enthusiasm in joining this year's Datathon.
Fantastic. And Leo, particularly given how we were introduced in terms of you know more about this data set than probably many of us on the phone combined, you were particularly interested, and Marzyeh as well, channeling her as she's lecturing, in some of these deeper research questions about the assumptions that participants may be testing when they're cleaning the data and trying different approaches in their models. Could you explain sort of what got you to this point career trajectory-wise, and what makes you excited about the potential of this year's data set?
Sure. So my name is Leo. I'm a practicing doctor, so my specialty is in the intensive care unit, but my research is here at MIT. I represent a large team of not just researchers here at MIT, but colleagues from around the world. And the reason why I got interested and drawn to this field is probably because of my frustration. So as a practicing clinician, I realized very quickly that most of the decisions that I make are based on my personal interpretation of what's happening with the patient. The guidelines, the vast majority of them are not really supported by sound evidence. Less than 10% of what we do is based on some clinical trial. Clinical trials, as you know, are very expensive. And the other important thing to note is that most of the clinical trials, I would say the vast majority of them, only happen in rich countries. So the medical knowledge system is by far predominantly really developed based on research that is performed on the white Caucasian male. The way medicine is practiced now is that guidelines are put together based on the research performed in the United States or Western countries, and they get adopted to the rest of the world. So the mission of our group is to put data, research, and learning at the front and center of healthcare. We feel that the findings that we have, the findings that inform the way we make decisions should not be based on research primarily on white Caucasian male, that everyone should be represented, including women and minority populations in rich countries. So our group is really focused on creating this ecosystem that consists of frontline workers, the doctors, the nurses, the pharmacists, and interfacing them with computer scientists and engineers. And the idea here is to start using data that is routinely collected in care that are now available in digital format, and make that resource available to as many brilliant minds, to as many perspectives as possible, to try to address the information gaps that we encounter on a day-to-day basis. I'm gonna stop there so that we could hear more from the other panelists as well as from the participants.
Absolutely. And for all of those participating, please feel free to, we have some starter questions for the panelists for you to get to know them, but please feel free to write specific questions. We absolutely want to hear from what's firstmost in your mind as you're thinking about forming teams to write the research papers and join us in this new Excellence in Research Award opportunity.
Hey,
for
Meredith,
those of you
can you
who
unshare your screen?
Oh, yes, yes. Let's see. With unsharing the screen, wonderful. Now we can see the chat window.
Yes.
We're no longer flying blind. Fantastic. Oh my gosh, you guys are on it with all of the questions. We have 126 participants. So panelists, I will ask you as well if you see anything coming in that you'd like to address right away. If you can read faster than me, please go ahead. And we'll try to scroll up and down and address some of these. One of the questions that some of the participants are really thinking about right now is what's really meaningful, what's been surprising as they reflect on their 2 months of working with this data set. And I thought it would be nice to parallel that question about lessons learned, things that have been really meaningful or surprising for you in working with health data. Not necessarily this specific data set, although Leo, I'm sure you guys have many lessons learned, but broadly speaking, are there any really salient points that you remember as like, oh, that was a painful or surprising moment for me, and how did you work through that?
Yeah, I can jump in.
Perfect.
Yeah, so I think one of the important things that I've learned since working with KenSci is really keeping an eye into what data is actually going to be available, you know, kind of at the point of prediction. So a lot of what we do at KenSci is actually applied machine learning to be used at the point of care. And, you know, clinically, when we're making these decisions, you know, we're very aware, obviously, of what data we have available, and whether we're waiting on a lab test to come back, or we're, you know, waiting on, you know, some other points of assessment to come through to make that decision. And some of that is really important to keep in mind also from a machine learning perspective. So, you know, which data points are you able to include in your point of prediction? And that's always an interesting kind of back and forth, I would say, with the data, is actually keeping an eye towards what would be available for this to be used at the point of care. And that's really, you know, the goal of what we're all doing, is to how do we make this actionable, and how do we make this, translate this to actually improving the lives of the patients we're taking care of.
I can jump in. So in my experience working with data, especially with sensitive data such as health data, the surprising part is, especially working in a big enterprise like Microsoft, the amount of time that you need to set aside in your project in just going through the compliance process and getting that data into the enterprise. And that's both like if you're getting data into the enterprise, and we run a lot of experiments sometimes with volunteer participants within Microsoft. So releasing that data also, you need to take into account the time and all the steps. You need to have a legitimate business process. You need to have a data retention plan. You need to have a clearance from a privacy and consent perspective. You need to have a very clear understanding of what were the participants aware of when this data was collected, and whether you have their permission in how you're using the data and how you will be releasing either the data or any product that is based on the data. Typically as engineers, we tend to overlook that part because we feel like that is just something that we'll deal with when it actually comes to the point of releasing a product or a data set. But that is something that absolutely needs to be included in upfront planning in the overall timeline that the project is going to take.
Okay, to me, I think the most important lesson that I've learned over the last decade is that what comes before the machine learning is so much harder than the machine learning itself. Like, I hate to say this, but the machine learning is the easiest part. The hardest part is to find the data and making sure that it has all the relevant features that you need. And then curation of the data is where we spend 90% of our time. And for the most part, that needs to be done very closely with people who were familiar with how the data was collected. And I think the machine learning community needs to invest more in contributing to the curation and the data collection and the data harmonization. So for now, the machine learning community is flocking to where the data sets are. And this may not be the most important questions that we need to address. Like, we don't really need another, I hate to say it, we don't really need another mortality prediction model. We need more models in primary care. We need more models in specialties where you have a dearth of randomized control trials. And I'm talking about obstetrics and GYN, I'm talking about pediatrics. There are very few clinical trials that are being done because it's very challenging to perform clinical trials with pregnant women or with children. And these are the areas where I think potentially data science could really have an impact. And of course, primary care, but we don't have any data sets in OBGYN. We don't have any data sets in pediatrics in primary care. And for that reason, the machine learning community is not really getting excited. They get excited about ophthalmologic images. I'm not saying that they don't have any value, but if you're gonna be prioritizing where are the areas where we need the help of computer scientists and engineers, I would tell you that it's in primary care, it's in other areas that are very underrepresented right now in the field. And there.
Let's talk a little bit more about representation. Marzyeh has a really great podcast through WiDS about the importance of broadening participation, and how she, you know, when she was a grad student herself, was grappling with the implications of different assumptions and looking at the prediction performance across different ethnicities, the gender spectrum, and other attributes. Where do you think there are both short-term things we can do to broaden participation and increase the representation of all the different communities that should be included in these studies? And what are some more difficult, further out things that we still need to keep on our radar if we ever want to try to make progress towards those bigger questions?
So I think a lot of the large data sets that we use, you know, do help with some of these issues. They don't alleviate them totally. As Dr. Leo mentioned, you know, so many of the RCTs that have formed the basis for clinical practice or other guidelines are, you know, based on a very small subset of patients that have very strict inclusion and exclusion criteria, so that effectively they very rarely apply to the patient sitting in front of you. So just the use of large data sets does help with this, because we can alleviate some of these strict criteria for inclusion and exclusion. We do still see, certain populations represented more, especially in data sets that are specific to one or two facilities. We know that certain groups of people tend to seek healthcare, at different rates or at different sort of consistencies of locales. So it's helpful to think about, how do we capture some of these larger sets? And I think, we did also mention about kind of the Western world, obviously, is also more highly representative in these data sets as well. So I think, some of these sets like the GLOSSIS data do kind of make strides towards being more inclusive.
I could add to that. So I think what Marzyeh was emphasizing is that we need to be paranoid about algorithmic bias. We need to make sure that the algorithms are performing consistently across different populations. And we have tons and tons of examples where we have discovered, for example, that some of the algorithms are biased against certain populations which were not represented well or were represented disproportionately in the training cohort. A more recent example would be the algorithm that will identify patients who will more likely require complex care, and the proxy metric that they use for complex care would be the healthcare costs. And the action that will be implemented once a patient is identified as being high risk for complex care is they get enrolled into specially resourced programs. So you could anticipate the needs that they will have in the future. And it turns out that the algorithm was biased against Black and other minority populations just because they're not seeking care. They're not being labeled as high resource or complex patients in the future. And for that reason, they weren't being enrolled in programs that would benefit them the most. So I think being aware that there is such a thing as algorithmic bias, that the way patients are being represented or the choice of your surrogate metrics could have a very marked impact on the performance of models is the first step. We're always paranoid that we will be contributing to health disparities, and that's the last thing that we need, is to make the status quo even worse. So there are ways of making sure that there's representation, and there are ways to increase the representation in your modeling, but there are also ways of evaluating whether one particular patient cohort could be disproportionately biased against when you start implementing these models.
There is an active field of research that is especially focused on healthcare machine learning, which falls under intelligibility or model interpretability. I know KenSci has done some interesting work here. Microsoft Research AI has also done some work here. If you look up a paper called Error Terrain Analysis, you can see the work that's being done to determine what incoming features contribute to the error rate in what machine learning models produce. So it is an ongoing and very active field of research, and it is definitely something that someone who is passionate about this area of increasing representation of all increasing representation in data sets and increasing and reducing bias in ML can work on from a computer science perspective. We are getting quite a few machine learning questions in the chat. There's one here that asks, do you use simple algorithms, that is linear or logistic regression models, or start with complex models like boosting? Are simple models used in production? I'll take a shot at this, and then maybe Dr. Carly or Dr. Leo can chime in. It really depends on what problem you're trying to solve, and it depends on the data itself. Rather than think about what algorithm you're going to use, it is more important to really understand the data. And you need to spend, like Dr. Leo said earlier, you need to spend a lot of time with the data and really studying the data to understand what methodology might work specific to the problem that you're looking to address. So there is really not an easy answer to that question.
Yeah, I would agree with that. And part of I think even before thinking about which algorithm, it's, is this a good problem for machine learning? That not all clinical problems, need to have a machine learning answer, and that kind of understanding what the baseline is and what is currently kind of standard of care in clinical use, and seeing, if this is truly a good question for machine learning to address.
Yes, no, I'm just gonna highlight that, and I think it indirectly answers one of the questions posted about as a data scientist, if you don't have any clinical background, I mean, how can you choose the right questions? And I mean, I think one of the key messages that we really advocate over and over again is that the machine learning community would need to work with the domain experts, the people who are familiar with healthcare delivery. So I keep telling the students here at MIT, you are not the first generation of people who have tried to transform healthcare with the use of technology, with the use of algorithms, and generations after generations have failed because this is a complex area. The other thing that's important to highlight is that at present, we are only using clinical data to try to predict outcomes when we know that like 2/3, they say, around 2/3 of outcomes are from social determinants. And for now, we're only using vital signs, we're using laboratory test results, and not enough variables to represent the socioeconomic status, the behavior of the patient. And that really needs to be included as features because they really represent the entirety of the patient. A good example that I see a lot of is trying to predict readmission. And they will try to predict readmission based on clinical data. If you ask someone who works at the front lines of care, they'll tell you that the biggest factors that would affect readmission are actually social factors. So homelessness would be 80% of your of the risk factor for readmission. If they don't have any address, chances are there's a high likelihood that they will be readmitted. But they're not included in the models that are being submitted to papers. So that to me points out the possibility that the data scientists are not working with the people who are familiar with the question. And you really need to work with them. Like the machine learning community cannot do this by themselves in the same way that the healthcare community cannot do this by ourselves too, because we need the expertise in data science. So again, I'm just gonna say out there that collaboration is crucial for this field to advance. We can't continue to work in silos as we have done in the previous century. Otherwise, we won't be able to really fix the problems that beset healthcare.
Absolutely, and inspired by what you all just said, we created a live polling question to see if folks participating in this webinar participated in the Kaggle leaderboard, whether you did this individually, whether you formed a team with people you knew already, new contacts, and I put a specific question there to address Leo and Dr. Carly, and actually you all mentioned this. Was there an opportunity to work with a health practitioner? That was actually one of the claimed secret sauce strategies of the first place team, that they found somebody who was an MD who could explain some of the context here. And it just serves to highlight the importance of multidisciplinary teams. You've probably seen the hashtag data science is a team sport, and we saw many teams noting that to better understand and look at the implications of their assumptions and their process in the Datathon, that having additional effort spent looking up what all of these codes meant for Apache, 3 and 4 and so forth, and asking medical practitioners was quite helpful. That's really the ethos behind phase 2, to encourage this deeper collaboration. And we just wanted to highlight, for those who may not have read it super closely in the FAQ, that we fully understand that maybe your team for the first phase of the Datathon, there's only a couple people or maybe only one out of the 4 who are interested in diving deeper and doing the research paper this month. If so, that's totally fine, and you're able to recombine teams with other folks. And we also specifically said that there's an opportunity to acknowledge mentors and sort of broader community members who are contributing, even if they're not on the smaller author list, and people who are submitting that paper for the Excellence in Research Award. So we hope that you'll keep in contact with the mentors and organizers with any questions as you're pulling together those papers, given how important it is to connect with folks outside of your field for this subject area. There's another question. There's quite a few questions. Thank you so much, everyone, for adding these. And it looks like the panelists can mark on the screen if they'd like to answer live or type a link. I think one that's important to raise, coming in from Redmi, is are you planning to release the test cohorts data set publicly? And how folks working on this specific data set that we curated for WiDS, looking at privacy concerns and so forth, sort of falls into the landscape of additional data sets of ICUs and the broader MIT Global Open Source Severity of Illness Score Initiative. Leo, could you maybe provide some additional context on the many types of data sets and the initiative that MIT GOSIS is coordinating?
Yes, so the data set that the people worked on is a small subset of a superset that has data coming from countries around the world. And just to give an overview of why this could be, this is an important question. It's not really the mortality prediction per se. The main use of coming up with an illness severity scoring is to be able to use that to adjust for illness severity when you're performing research. So it's very important to be able to compare apples and apples, oranges versus oranges, as you know, when we're developing models or we're trying to address an epidemiologic question. And this is what is going to be used. So at present, the best illness severity score is Apache. And when we perform research, we include that as a covariate because we think that it is a good marker of how sick they are. And this is with respect to how that translates into a mortality risk. But as we know, at least in the critical care community, Apache only performs well in the United States because it was developed using data coming from ICUs in the United States. Its calibration is definitely suboptimal when you start using that for data coming from Brazil or coming from the Philippines. So we need an illness severity score that will be reflective of illness severity as applied to patients across the globe. And that's really the main reason why we decided to put together this data set. And so that there will be representation of patients from around the globe in terms of coming up with a good metric to represent how acutely unwell they are when they first come into the United States. We have other data sets that are available that we have released to the public. So MIMIC comes from one hospital, which is the hospital where I work in. There are efforts now to expand that to include data outside of the intensive care unit. So increasingly there's interest of not just the ICU, but again, primary care is one of our pain points. So I think data coming from primary care would also be very useful. We have a data set consisting of chest x-rays, so images, and these are linked to how the radiologists interpreted them, but also in the next iteration of MIMIC, the actual image will be linked to the clinical data that pertains to that patient. So we are excited about that. I think we're going to be discovering new patterns that we've never even considered before. So those are some of the data sets that are available now. And then we're working with hospitals around the world. We're working with universities. As I said, our mission is that we are able to replicate what we're doing here in Boston and Cambridge and do this in other parts of the world. So it will be great if every hospital will partner up with a university and together they analyze the data coming from the local patient population, and you develop models that are specific to your population rather than adopt the models coming from MIMIC or coming from the US hospitals. So one of the questions is how can we be more involved? And I say you form your own communities there locally. From the machine learning community, from the Department of Computer Science, reach out to the local health organization. There's increasing interest in what we're doing, and I'm pretty sure you could gather steam, you could drum up interest, and form your own group there that will really advocate for your own patients.
Also, we can share the link for the PhysioNet community, which has a nice index for a number of different relevant resources, whether they're data sets or actually for the first time ever, we had the WiDS Datathon listed as a challenge for PhysioNet. So you can, we have the digital object identifier and connect with other folks who are citing similar projects. And this is not just for Leo, but opening it up to Vani and Carly as well. There have been a number of comments. With the time, I'm trying to group different questions that look similar. And one participant, Malasi, was noting sort of the time scale that every day there's some new knowledge or potentially progressions of diseases and conditions and greater understanding being distributed across the world. Could you maybe comment in your experience on the time scale of, I know it sounds trite, but the timescale of healthcare innovation, like what is the rhythm and how has that sort of changed from when you were a student? And actually, I know, Carly, you're still a student of some shape or form, right? But what are sort of levels of time in all of this community engagement and progress?
Yeah, that's a good question. I think the timescale certainly seems to be, I would say it seems that the kind of time to innovation in healthcare certainly seems to be shortening, I guess, in terms of the timescale. Typically healthcare journals are, where a lot of the research innovation is obviously published and where sort of some of these findings are circulated and eventually implemented into clinical care. It's been really interesting the last 3 or 4 years, especially as I've been more in the informatics and machine learning field, to kind of watch how that field has permeated these said journals. There's certainly been sort of an I guess, an increase in prevalence of these, machine learning publications actually in clinical care journals and outside of the computer science literature. So it's been really exciting to watch, especially, also in healthcare meetings. And, I still go to a fair number of clinical conferences, and actually watching, especially some of the older and established physicians talking about machine learning. So I would think, it seems to me that this time frame of innovation is certainly shrinking, and the acceptance of these, more innovative research approaches seems to be permeating the field more easily.
Okay, I think I'm properly unmuted.
As
Vani,
well-
do you have any thoughts on that? I mean, beyond health data, you've seen data science innovations through a number of different fields, through the big data innovation hubs and your work at Microsoft. I'm thinking transportation and other areas. Is there anything unique about the healthcare space that gives you pause in terms of the timescales of innovation?
Oh, absolutely. I feel healthcare is a fairly difficult space because lives are at stake, as opposed to some of the other AI fields that we are engaged with. And the data is extremely sensitive. The protections are, as they should be, very stringent, and it is highly regulated. Which is good because some of that work has already been done from a regulation point of view, but from a technology point of view, there tends to be this almost glacial pace at which things move because of some of these, barriers that you must cross in order to continue to evolve the technology around healthcare systems and healthcare data. And then the other part of it is also, disrupting an industry that is very entrenched in its ways, and that, is a very large industry, very large, very visible industry. So Microsoft is, doing more and more in this space now, but as you know, Meredith, last year it was such a slam dunk to work on the deforestation data set, but this year I felt like I did not have, the time. I know the Datathon participants have been, you've had a tremendous response, but I felt like even I did not have the time to onboard this data set and work with it, in the time frame that was available for the Datathon. So absolutely, it's an important field. It's a very hot field. So in terms of, there's been quite a few questions from folks who are new to data science, and I would definitely encourage them to consider healthcare data science as a field in which they want to study or seek employment. But I do feel like it is, very, there's a lot of challenges, and with all those challenges, there are a lot of opportunities as well. And I have there's been a couple of questions about policy. So that's something that might be a good thing to discuss with Dr. Leo and Dr. Carly here, especially, what are the policy changes, or do you have any thoughts on, what healthcare policy, or what policy changes do you feel need to, we need to be thinking about or pushing for in order to make this field have greater impact?
I'll start off, and I think that there has to be more regulation around transparency in what you are doing with the data. So public trust is definitely a requirement for this field to move forward. We can't be caught sort of red-handed and be discovered that we're using the data to maximize the profit of the insurance company, which was what happened with Project Nightingale, for example. There were some internal documents that were discovered saying that the reason why data analysis was being performed was to identify patients. There are missed opportunities where they could have offered procedures. So it becomes a problem for us because the public now thinks that we're using data science just to maximize profit. And I think there should be more regulation in terms of making known what your intentions are, exactly what are you going to do, what are the analysis that you're going to be performing, because those are crucial to gain public trust. So I'm actually more for regulation. Like I don't agree about self-regulation. So there are a lot of discussions around ethics, whitewashing, and ethics bashing. So, some people are perceiving all this interest in AI ethics as a lobbying effort, for example, by the tech industry to be allowed to self-regulate in terms of how they use the data. I'm actually all for more regulation, and I think the regulation should be making it transparent, making it clear exactly what am I using the data for. So I'm hoping that's what we're heading. I'm not against the interest in AI ethics. I think that's a good thing in general. But at the same time, the way to address that is complete transparency, complete honesty, making the data sets publicly available, and also I'm hoping that we could have policy really push forward our intentions of promoting collaboration. So our group is really pushing for sharing the queries and the codes. I'm hoping that WiDS would also do that. Once this competition is over, then the codes, the GitHub repository should be shared so that other groups can replicate, other groups can build upon the research that are being done by other groups. So it's time to change the way we perform research. If we continue having the same approach, I think we're going to have issues with reproducibility. We're drowning in data, and there's more and more interest in data analysis. If we continue what we have been doing in the last century, then I think we're going to be swimming in garbage publications. We're going to be swimming with more and more claims of better performing algorithms without the ability to really check whether those algorithms are indeed better than the ones we've had before.
That's a great point, Dr. Leo, and that's one of the visions that we have with the Microsoft Research Open Data, where we want to make data and code available alongside the publications, so that you could instantiate a cloud computing asset against the data set and just through a very seamless manner reproduce the work that was in that publication. I think Dr. Kali, you were about to say something.
I was just going to say, I certainly agree that, the level of transparency for public trust is going to be key, and will continue to be key. And the collaboration also mentioned is effective, is critical, that these are really difficult problems, that healthcare data and healthcare problems are super complex. I just wanted to extend that to say that, beyond just the public trust, it also comes down to the user trust. And the physicians are very protective, as they should be, of patients and of how they take care of their patients. And so also ensuring kind of the transparency of what we're doing to the level of the end user, so that the clinician or the healthcare provider can actually understand, how these models are being implemented or are being used, and also, how these predictions or how these different, end results are actually being made on the patients that are sitting in front of them.
And just one short addition. In the end, we are not interested in the AUC. As clinicians, we're interested in how the algorithms will improve population health. Will it increase survival? So again, as machine learning researchers, we're all about performance of the model. But in the end, it doesn't matter to the patients. If it doesn't improve some metric that they value, then it's useless to us. So, and this again highlights the importance of working with the clinicians, because our goal is not to just develop the models and publish them. Our goal is to get these algorithms to the bedside. And that, again, is just as complicated as what it takes to get to the machine learning part. So what comes before and after the algorithms are much more challenging. I think as a machine learning community, we have to be interested in both the pre-machine learning and the post-machine learning. And we need better perspectives to join us in terms of pushing these algorithms, not just to the bedside, but also to the policymakers.
There's a question about missing data and what are the strategies for dealing with missing data. A couple of, not speaking to this particular challenge, but a couple of strategies is to ensure that the features that you're using in your model do not depend on some of this sparse data. And the other is, of course, to create synthetic data that follows the same distribution as the sparse data that you have, but you need to be very aware of those options and those choices that you're making, especially when it comes to creating synthetic data. But again, it depends on the specific problem that you're trying to solve. And a lot of times it's easier to just exclude those features from the data set before you consume it for a model.
I would also add that's another kind of situation where it's really important to have good collaboration with your healthcare professional or with sort of your clinical subject matter expert, because there's a lot of signals sometimes in the data that we're considering is missing, that you can actually learn something from the patterns of missingness before synthetic data or other approaches are used, that can be pretty powerful for the models depending on the situation.
Absolutely, and knowing that the phase 2 one-page research papers deadline is coming up quite soon, we've particularly phrased the prompt questions for that in a way that we hope is an on-ramp, even if you haven't yet connected with a healthcare data practitioner. The folks reviewing those one-pagers are looking for not only the most meaningful contributions and insights and surprises that you found along the way when you were getting your hands and computers dirty with this data set, but also what unanswered questions came up for you as you were testing your models and looking at different ways to analyze the issue. So please do include, ideas on how you and others might address some of these unanswered questions, knowing that those elusive healthcare practitioners that apparently not many of the folks polled could find during the last 2 months, they will be reading those papers and want to see your ideas in terms of how you could collaborate with next steps. So we're coming up on time now. I will try to, when we remove the video and get kicked out of these conference rooms, I will still keep the Zoom open to try to resolve some of these specific questions that people have put in the chat window. But for all of the panelists, it would be great if you could just share in the last minute or two some of your favorite resources or advice that you have for next steps for the participants who want to continue to work in this space, hopefully long after they've written their papers this month.
I think I just typed this answer to a question in the chat window as well. I think experiential learning is very important in this field. Taking part in the WiDS Datathon is a great first step if that's not something you've done before. Generally looking for these kind of challenges on Kaggle is great. And then also seeking a data science problem in your current role, whether you're a student or in industry, is very important. There's always a lot of great data that is waiting to be used, and there's a lot of great problems that you can solve by asking the right questions and collecting the right data. So my advice would be to take up one of those kind of problems that your organization is dealing with and teach yourself through that sort of experience.
Yeah, I would just add to sort of try to remove some of the silos between data science and healthcare, which is obviously why we're here and what we're trying to do. But even if there's an opportunity for if you have a mentor who's a healthcare professional, to see if there's an opportunity to shadow them perhaps in a clinical setting, or to get a better understanding of kind of how this clinical data is collected and how these clinical problems and predictions could actually be used at the point of care. That can also be things like, reading clinical journals. I think seeing the cross-disciplinary research published in some of these more clinically oriented journals can be a really helpful way of understanding what is being talked about in this setting, and they can go a long way towards informing how we understand each other across different disciplines.
So from my end, I would say consider going back to school. Look for opportunities that will fund going back and doing a master's program. Apply for a Fulbright scholarship. I've encountered so many people during our events around the world. We've encouraged them to apply for Fulbright or for some other scholarship from their local government to try to come to Boston. It's an advertisement, but I think in terms of healthcare technology, health data science, I mean, I'm biased, but I think nothing comes close to Boston and Cambridge. So look at those opportunities. These are opportunities for you to grow both personally and professionally. So consider taking a break from your job now if you're working, and see where. And I think it will be worthwhile to get a formal education in this field, and that also would be an opportunity to enrich your network, because when you come here, you will meet so many brilliant people from around the world, like-minded people, and I think it will definitely contribute to your personal and career growth.
Well, I just have to provide another end of that spectrum, having spent 13 or so years in school at Stanford for electrical engineering for 3 degrees and a postdoc with medical professionals. I think there are also ways where you don't have to spend a decade necessarily, and can have the more informal learning opportunities through efforts like the WiDS Datathon or this Phase 2 research paper. The WiDS Datathon and WiDS Conference Committee is really excited to see a lot of folks participating in our survey who have said that this is the very first time that they've had a chance to work with healthcare data. And although they may not have gotten the exclusive prize package with the invitation to Dr. Leo's Datathon in Brazil as the top prize, it still sparked some interest and a desire to have this conversation and tune in to things like this webinar and continue that discussion. So I hope whether you're all ready to pack your bags and go to join Dr. Leo in Cambridge, or if you're staying put and wanting to learn a bit on the side, that you feel welcome and a sense of belonging thanks to all of the efforts of our panelists and the folks working this year on the Datathon. So it looks like we're just at time, so I wanted to just thank everyone again for their participation. As soon as you close the webinar chat window, you'll see the link to our participant survey. We want your data in terms of your participant experience, not just for the webinar, but for the Datathon broadly, and that really helps us to continue to provide Datathons moving forward and to expand upon the types of resources that we're sharing and help facilitate this deeper engagement through Phase 2 and beyond. So thanks so much, everyone, for sharing a bit of your day today, and to everyone tuning in remotely. Have a great rest of your week as well. Take care, everyone.
Thank you.
Thank you.